We're going to be speaking on medication abortion. And the first speaker is Dr. Sheila Dunn. Dr. Sheila Dunn is a family physician at Women's College Hospital in Toronto and an associate professor in the Department of Family and Community Medicine at the University of Toronto. She has an MSc in clinical epidemiology from the University of Toronto and has been actively involved in clinical care, teaching, and research in women's reproductive health for over 25 years. She is a scientist at Women's College Research Institute and the research director of the Department of Family and Community Medicine at Women's College Hospital. Her research interests include medical abortion, emergency contraception, health equity, and cervical screening. And she is going to be speaking on the status of medical abortion in Canada, including worldwide data. So go ahead, Sheila.
I will. I hope I can find, thank you, Patricia. See if I can actually do this. It looks like there's 9 people in this group, and I sure wish I knew I could say hi to you all, because it would be, it's a small enough group, we can potentially, we could do that at some point. So I actually hope we can have a conversation at some point in the end. But thanks so much for inviting me and giving me the opportunity to spend an hour and a half with Edith, which is great, because you can tell that we don't see each other as often as we'd like. Yeah, so I'm going to set the stage for Edith, I hope, a little bit by talking about what's happened with abortion in Canada since we have had mifepristone available, and really put it into some global context for you, and just review a little bit of research that we're have undertaken and some of the results we found, which I think might be interesting for you. I have no conflicts to disclose. I do get some funding support from my hospital and from the Department of Family Medicine at University of Toronto. And with the research that I'm going to present, none of the investigators in the work presented have conflicts to disclose regarding the research. So just to give you some, the pre-mifepristone background, prior to mifepristone availability, there were about 100,000 abortions per year in Canada, fairly, maybe declining a little bit, but fairly consistent. The vast majority were surgical. And abortion access varied really considerably across the country. It was mainly geographically inequitable, in a sense that if you weren't living in an urban center where you really could fairly easily access an abortion, you could have to travel long distances. You might actually have your procedure delayed because it took you longer to get to a facility to do it. Now, that was a little different in the province of Quebec, which has quite distributed abortion services, but in the rest of the country, certainly there were considerable geographic and continue to be geographic inequities in access, such that in 2016, the UN Human Rights Commissioner called on Canada to improve inequities in abortion access. And then came mifepristone, and this is a really old magazine cover from actually the year 2000 when mifepristone was approved in the US. But actually, you could say something similar for Canada, really. This has really changed the landscape of abortion care. Now, the US has had this now for over 20 years, and I would just give you the information that the last I looked at, CDC reported that about, I think it's 42% of abortions in the US are now medically or medication-induced abortions. And that's over the period of 20 years. So very, very big change in the provision of abortion care. For those of you who don't know, you probably do, but I'll just review it. The product we have available is a combined product, and that's it is available in some countries around the world, but some countries actually only have mifepristone alone available and have to use it in a, as a dual kind of prescription with misoprostol. It was approved in 2015, but wasn't available until January of 2017. And our product is 200 milligrams of mifepristone, which is given orally and then followed 24 to 48 hours later with misoprostol, which can be administered either in the cheek pouch buccally or vaginally. And with expulsion of the products of conception usually happening in about 2 to 8 hours after administration of the misoprostol, which is a prostaglandin and causes uterine contractions. Sorry. So around the world, if you look at this map, you can see we're in teal. Now I'm going to see if I can use my little highlighter thing here. I don't know if this will work or not. You can tell me if it will. Can you see this here? No. Yes?
Yeah, we see.
You can see it. Oh, good. Okay. So in 2015, that's where we are, but you can see that the availability in some parts of the world it was available in France first in 1988. So we were very late comers to the game in terms of having it available. Since Canada has approved it, you can see there are countries in South America and West Africa that have approved it. But by and large, we're a very late comer to availability. We really were annoyed and upset about that for many, many years. But in some ways, we may have had some advantages ultimately in terms of where we're at right now because of that delay, because there was so much experience with it around the world, so much evidence about how it could be used, et cetera, that we weren't first comers to having to find that out, as they would have been in countries that got it very early on. So mifepristone is used widely around the globe, but in Western countries, such as Canada, like that would be the US, Australia, the UK, and Europe, there are restrictions on how it's used. And that's either because they have abortion laws that may restrict it or regulations that may restrict it. And that they may restrict where you can provide abortion, so that you can't provide it other than in a facility that provides abortions, or who can prescribe it. There may be specifications about training, et cetera, that a prescriber might need to have, or the kind of professional certification, et cetera. There are regulations on how it's dispensed and where the drug must be taken. So until recently in the UK, it had to be taken, excuse me, in an abortion facility. So there are many, many restrictions about how it's actually used that have really impeded its, what I would say, its uptake into community practice. It's been more localized in facilities and in special places that provide reproductive health services. And our initial Canadian approval in 2015 had a lot of those restrictions. These are called risk evaluation and mitigation strategies, which the ones that we had in our approval in 2015 were similar to some of them in the US and Australian. And that was that only physicians and pharmacists who had certified training and were registered with the manufacturer could prescribe or order it. And only the prescribing MD could dispense it. A pharmacist couldn't give it to a patient. The patient had to be witnessed ingesting it. There was a pre-specified consent form that had to be used, and an ultrasound was required. Now, if you think about the potential for this to be used in a family practice office, et cetera, certainly the requirement that a physician's office would need to order and then dispense a drug would not make that happen in any significant way. I don't think many physicians who weren't part of a large facility would actually get involved in that. So that already these were restrictions that really limited its usefulness. And so the CARP mifepristone implementation study, which started, I think it started in about 2016. I can't remember the start date, but Edith and I were involved in this. And this project really aimed to optimize the potential of mifepristone to improve the equitable access to abortion. And that specifically, we were kind of trying to target community primary care providers that could be distributed across Canada, and potentially, if they took it up, reduce some of the geographic inequities that are present here. And we were doing that by identifying and addressing barriers and facilitators to implementation through integrated knowledge translation with health policymakers were part of our advisory group and part of the team, where they were enablers in terms of mitigating these regulatory barriers if we found them. And then we had a virtual community of practice to support practitioners with tools for practice, etc. But also the community of practice helped us gather real-time data on what their experience was of barriers and facilitators that we could then feed back to our knowledge users. And this is the team, and you don't need to pay a lot of attention to it. The lead investigator is Wendy Norman, who's so well known in Canada for so much work she's been doing in reproductive health. But if you look, the knowledge user to the right is Supriya Sharma, who is like, we've been seeing her talking about COVID vaccines, et cetera, every few days on the news. Supriya Sharma in Health Canada was really involved in our knowledge user team and was right there getting the input about what kind of regulatory barriers our practitioners were experiencing, and was really wanting to know that information. This is the invitation card to CAPS CPCA, which is the virtual community of practice that we created. And just to kind of whip through this material, but the community of practice has, and it still has, because it's still running, although it's going to have a limited lifespan in its current form, helpful resources like information for patients that could be distributed, consent forms, et cetera. So people didn't have to reinvent the wheel when they came to integrate this into their practice. This is just an example of the medical charting form, which people could pick up, and pretty much it's pretty much a recipe for providing mifepristone abortion care. So it really covers everything in a checklist sort of form. So these tools were really well used. This particular form and another one for pharmacists were downloaded something like 8,000 times. They were extremely well received. And we also had an Ask an Expert function in the community of practice, which somebody who was new and didn't know what to do or might be isolated and had a question about how to provide could send a question in, and Edith maybe, or myself, or some of the other team members would respond within about 24 to 48 hours to see if we could help support them with some evidence-based suggestions. We collected data about this study through surveys of our physicians and pharmacists, and there were 3 of them that were done, and interviews with pharmacists and physicians and health policymakers, and then data from some of the metrics from the community of practice. So just to get an idea of what, this is a graph of the membership of CAPS over the first, it's really over the first 3 years, I think. And you can see that it's still growing at the end of, that was almost a year ago now, but it was still growing. These are the physician members in blue. And they continued to rise throughout 2021, actually. Throughout the time, we've now got nurse practitioner and midwives that have been allowed to join the community of practice as well. So the membership is still growing. The survey of our physicians, this was done a little bit earlier on, but just to give you an idea of who's involved in terms of the the breakdown of who's joining this. Most were family physicians, very well distributed across the country from the territories all over, except, and Eve may speak to this later, Quebec is underrepresented, and I'll get back a little bit later about why that is. All our materials were in English and French, or French and English, and we certainly tried to make information available about CAPS CPCA, but our Quebec representation was lower than the actual population in Quebec kind of warranted. The other interesting thing to look at, I think, is that the representation from rural areas, according to how these are outside large metropolitan areas, 29% of the Canadian population resides outside a large metropolitan area, but 55% of our members did. So it seemed to attract people who were in more rural practice. And it also attracted about over a third of the members had no previous abortion experience. So people who were new to abortion care. And that is really who we were trying to reach with this to try and support the uptake of this practice in primary care. Sorry, I'm missing this. Sorry. There. When we looked at 6 months, you just follow up with the physicians. 2/3 said it was very useful, and the kinds of things they really valued were the resources I showed you, those downloadable practice supports, emails which we sent to keep them up to date with regulatory and policy updates, et cetera, and a sense that they belong to a community. And I don't know how important this is, but we had a sense that because stigma is such a large part of the experience of stigma is quite significant for a number of abortion providers, and it may, or the sense that they're going to be stigmatized may keep them out of practicing abortion care. We thought that having a community of support would be an important thing for people who are considering doing it, and maybe would encourage people who are just considering it to actually make the move to actually pick it up. What we didn't have in our virtual community of practice is really formal mentorship. And we did hear that there was a strong desire for locally available mentors, someone they could call, someone that was in a community nearby them that could provide that. So that's kind of a little gap in terms of what might be useful to support practitioners to pick this up. And then a real uncertainty about how to make availability of their services known. So there's a few people that were in smaller communities and said, you know, I'm prepared to do this, but I don't want to be advertising that I'm the physician who'll provide medical abortions. And I don't know how to get that information out. So I think that continues to be a problem because there's women who want to have a medical abortion in various areas of the country who actually don't know where to get it to. So it works both ways. And I think that's something that we still have to address in terms of service provision. After 12 months, almost 80% of the physicians who responded to our surveys had implemented mifepristone abortion in their practice. And that included 65% of those who had no previous abortion experience. So these aren't huge numbers, but they are significant in the sense of how many providers there are in Canada overall. So we were very happy that we actually were able to attract new providers who had no experience. One of the things we did, and this has to do with the kind of trying to eliminate some of the regulations that might have impeded uptake, was poll our membership. And one of the questions, or one of the polls that went out, asked the question for the physicians: do you agree that mandatory training should be required? And do you agree that your personal details should be shared with a pharmaceutical company that manufactures and sells a related drug, which is what was happening at the time? And you can see that 80% on both aspects of this said that they disagreed with that. And we fed that back to Health Canada. And in fact, over the first year really of this availability of the drug, there were a significant number of changes that really changed how people would use this drug. Before it even became available, that requirement for observed dosing was removed, which I think there was a large amount of embarrassment by the government that such a paternalistic type of, it implied women wouldn't know how to take it, that they wouldn't be responsible, et cetera. And the press they were getting on that, I think, had them kind of pull back on that. That was my sense. But by November 2017, regulations had changed such that prescriber training was not mandated. There was no required registration with the manufacturer. There was no registration with the manufacturer, not required, not required. Pharmacist dispensing was permitted. And with that, mifepristone was then available as a regular prescription like any other drug. And that to me opened the door really widely for it to be taken up by people in general practice. Prescribers were expanded to include nurse practitioners, and the initial gestational age limit, which was 49, was expanded up to 63 days. In practice, people are using it up to 70 days. And that's the evidence-based, it's evidence-based that it's actually effective and safe up to 10 weeks. And it may be beyond that, but not great evidence to that at this point. And by November 2017, in Ontario, certainly, and most of the country, drug costs were covered. Over the next year or so, it is actually covered across the country by provincial health insurance, or interim federal health will cover it, and the Aboriginal, what is it called, NIHB. Anyway, those benefits cover it as well. And the ultrasound requirement has been removed as well. So Canada's in a very unique position. We have no criminal law on abortion. I think there's only one other country in the world that I'm aware of that has no criminal law. Mifepristone is available like any other medication. That's not the case in other countries. Nurse practitioners can prescribe in many of our provinces. We have universal coverage for health services and drug costs. And with that, we have the potential to really diffuse this widely. And thus potentially could address inequities in access. Just to contrast that, I mean, this isn't really related, but I couldn't resist putting this in because the landscape is so different south of the border. And I think we're all waiting with our bated breath to hear what happens there in that eternal fight that they have in the US with abortion. But getting back to Canada, and sometimes it's wonderful to know we live north of the border. Most of the time it is. I just want to give you, just spend the last few minutes talking about this study because we have some interesting findings, and we were able to examine, take a look at the impact of mifepristone availability on abortion utilization, safety, and ongoing pregnancy. So what the outcomes were on these, these outcomes were after this was implemented in 2017. And this is the CART-MIFI outcome study, and it's an Ontario study. It's supposed to be, we are going to be getting data from BC, but we haven't actually received it yet. So we have the good fortune to have really very good population-based databases and administrative databases that enable us to really create a very, I would say, valid and robust cohort of people who've had abortions. And we actually got a cohort of people having abortions between January 2012, so well before mifepristone was available, up until March 2020, which is right at the beginning of the pandemic. And we looked at an interrupted time series to look at abortion rates and like its utilization and its safety and rates of ongoing pregnancy before mifepristone became available and afterwards. And this is what we found. And I mean, the most dramatic thing we found is right here on top, which is the percentage of medical abortions went from 2.2% pre-mifepristone to 31%. This would be 3 years after introduction. And now if you think about the US, it was at 41% 20 years after. So it just took off here. And that to me is maybe potentially one of the advantages of having access, getting this available later and not earlier. There was a lot more familiarity with it. Just to highlight what went on in Quebec, though, and thank you, Edith, for the reference on this, the percent of medical abortions in Quebec in 2020, same time, was only 12%. And Edith can speak to that, but across Canada, I've talked about the regulations being removed and really the way paved, but uniquely in Quebec, the physician licensing body actually did have some regulations restricting some of their physician activity that really appeared to put the damper on this. And Edith can speak to more to that later if she will. The abortion rate, you can see, did not go up. Everybody, certainly in the US, would fear that the abortion rate is going to go up if we make it easy for women to get abortions, and it did not. The severe adverse events did not go up. The complications did not go up. And there was a small increase in aspiration or reaspiration, and that's really expected because medical abortions are associated, a small number, with retained products of conception in a way it's a little more common than it would be after surgical abortion, but still not very, not a large increase. Ongoing pregnancy is another, I guess it's another concern that's been expressed. What if women take this at home and they're not followed well enough? What happens, etc. Well, there was an increase in pregnancy continuing to delivery. This would include women who changed their mind, never took the drug. And it may include women who took the drug and it failed and did not go on to have an abortion. We don't know. We do know that the subsequent abortion, the increase in subsequent abortion would actually include similarly women who it increased from like 1% to 2.1%, so increased by about 1%. That would be people who changed their mind about having a surgical abortion. They may have come in and asked, and we categorized them as having a medical abortion, but they changed their mind before they took the drug and had a surgical abortion. And those for whom the regimen didn't work and they had a continuing pregnancy. So again, 1%, but not very high and not unexpected. And then the ectopic pregnancy detected post-abortion. This looks like it went up a little bit. When we looked at time trends, we have trends and we're comparing trends. This is just the incidence rates. There really was no increase in this. And in fact, there was certainly no increase in complications due to ectopic pregnancy. If ectopic pregnancy that is picked up after abortion is provided, it is not a problem unless it's not known. And we have very, very good follow-up protocols for people where we're a little bit unclear about, if they're very early and we don't see something on an ultrasound, there's very clear protocols for specific follow-up, which would allow that ectopic pregnancy to be picked up potentially earlier than it would have declared itself clinically anyway. Sorry. So the impact of mifepristone availability without restrictions, I would say that you could see the rapid uptake of medical abortion. There's an expanded pool of providers, largely family practitioners, but there are OBGYNs and an increasing number of nurse practitioners, and there are more rural providers. And we have data that I haven't shown that suggests it's 3 times as many people are providing abortions now compared to that period that's pre-mifepristone. So whether this improves access to abortion, we don't really know, but you'd have to think that it won't hurt it. We saw no increase in abortion rates or adverse events or complications. So abortion remained safe despite it being available in a sort of unrestricted way, like a regular medication. And continuing pregnancy to delivery was very infrequent. And this information, which we actually could do here, and they haven't been, it hasn't really been done in other countries, is important for Canadian and international regulators who are considering whether they can change some of the way that drug is regulated in their countries, including the US, which is looking right now at its REMS restrictions that they have. So just to sum up, the history of mifepristone in Canada it was a long time coming to July 2015 when it was approved. And throughout that time and continuing, research and advocacy continues. But July of 2015, it was approved. January 2017, it was available. November 2017, it was available with all these regulations removed. And then in April 2020, the pandemic hit. And Edith's going to talk about changes that they've certainly been accelerated by the need to adapt abortion services during the pandemic. And I think that's the next step with, I think, the kind of way abortion care is provided. So just acknowledgements and yeah, thank you. And we can do questions now, or we could move on to Edith. I'll leave that with you, Patricia.
I think we'll do the questions. There were a couple of questions in the chat. Actually, Edith was a comment, but in the chat, there's a question. Is this correct? Sorry. Is this correct that abortion pill now is being bought online with home delivery, particularly during COVID?
Well, I think that that's the case. I've heard of that happening in the US. I haven't really, it's a good question. I haven't heard of that specifically in Canada because it would require to get it covered, and it's expensive, right? It's about $300 for the drug. You'd have to have a prescription. So, if you had a prescription that you could fill online, I guess, and it got covered, I guess that it potentially might happen. But you mean buying it on your own without any prescription? Is that right? Like a self-induced medication abortion?
I wonder if that is happening or not.
I have not heard about that other than some talk about it happening in the US. I don't know, Edith, if you have.
I know that there has been in 2021, from January to July, and it's still continuing, some demands to a special organization which is called Women on Web, whose executive board is now in Montreal, and they have received 137 demands for telemedicine abortion. The problem is that they don't have any physician in Canada able to respond under the umbrella of Women on Web. So what they have done since then, they have referred the patients to the providers, the abortion providers that they knew all over the country. If there are some women getting pills through the mail, it is possible, but we have no data on that. There has been a study done in the US where they tried to gather information on women getting abortion pills or abortion products through the mail, and they asked questions to several thousand women, and they observed that barely 30% were really obtaining abortion pills, because the rest of it were contraceptives or emergency pills or all kind of herbs and whatever. So it was not really very good.
Okay.
Thank you.
I don't see any other questions here, so I think we will move on to Dr. Edith Guibert. Edith has been a staff member of the Family Planning Clinic of the University Hospital of Quebec from 1979 to 2017 and headed it from 1987 to 2001. She is still a senior medical advisor for the National Institute of Public Health of Quebec, an associate clinical professor for the Department of Obstetrics and Gynecology at Laval University, and a medical advisor for the Pediatrics Department of the CHUQ. She holds a master's degree in epidemiology. She has been active in clinical and public health research in contraception and abortion, as well as in teenage pregnancy prevention and access to abortion care. She is one of the directors at the executive board of the SOGC, where she represents Canadian family physicians. She's also a member of the Women, Peace and Security Committee of our own federation, or I think until just recently. So go ahead, Edith.
Thank you. Thank you very much for this invitation. It's always a pleasure to present, and especially to be with my dear friend Sheila that I don't see too often. So we exchange a lot of mails, but we don't see each other very often. So my disclosures. I've been part of the advisory board of Women's Health of Bayer Company until May 2021. I've been remunerated by Searchlight Pharma for one conference in June 2020, and I'm on the executive board of the Society of OBGYNs of Canada since 2016. And I'm also, as Patricia said, on one committee of the Federation of Canadian Women, Medical Canadian Women. Okay, so I will talk to you about telemedicine medical abortion before COVID, and then the influence of COVID on the practice of medical abortion, and a little conclusion. So before COVID, telemedicine for medical abortion already occurred. And why did that occur? It's because abortion services for some women was very far from their home. Their personal schedule was incompatible with clinical consultations in an abortion clinic. Of course, traveling, daycare, work loss was very costly for these women. And most of the time they didn't have coverage by insurance. And they needed confidentiality, discretion, intimacy. And especially in the US, there were some hostile environment near abortion clinics. So really, the telemedicine started before COVID, and especially in some places in the US. But in Canada, it started first in Vancouver, in the clinic of one of our colleagues, Dr. Hélène Wiebe. So there, you know, I would say that the way that telemedicine was given was very variable from one project to another before COVID. In this study of Grossman and Grindley, which was published in 2017, they tried to compare medical consultation via telemedicine in a remote site with an MD, with a physician who was in a central site. And the dating ultrasound was done in the remote area by a technician, and the mifepristone was giving hand-to-hand at the remote site, but under the supervision of a physician in a central site. And they compared the women who had service in the central site to those who had service in the remote site. And I will show you the results very soon. Then we had also a study of Hélène Wiebe from Vancouver, who published in 2020, and she compared two cohorts. One cohort who had their service at the clinic in Vancouver, and other women whose residence was more than 2 hours from the clinic, with whom she had video communication by computer or cell phone, and they, in the remote site, they had access to a lab, to ultrasound if needed, an emergency clinic for curettage if retained product of conception would occur. And they did a follow-up by telephone. So that was another way of doing telemedicine before COVID. Then you have all the studies of Gompertz and colleagues and Godfrey and colleagues in the US with these online consultation with a special questionnaire and more or less a consultation with a physician if needed. In both organization, Women on Web or Aid Access, the women are sent the mifepristone by mail. They can access the helpline if they need anything during the process, and there is an online follow-up with questionnaire. So this is very much different, with very little access to health professionals. Finally, there is this initiative in Indonesia that was an online, they compared an online consultation with healthcare professionals for pre, per, and post medical abortion. And they compare it to an online consultation pre with all other instruction on a cell application for the rest of the medical abortion process. and the follow-up was done with Dextrose or by telephone 24 days post medical abortion. So let's see what happened with these all different initiatives. So, whoops. As of the study of Grossman, they compared the major adverse event or emergency department visit with treatment for the patients who were seen by telemedicine in a remote area, and those who were in person in the clinic, and they found absolutely no differences for any major adverse event, hospital admission, transfusion, or emergency department visit with treatment. If we look at the study of Ellen Wiebe, the study of Ellen Wiebe, where we were comparing these in-clinic patients and telemedicine patients, they were about the same age. The only difference was the distance to clinic, which was much bigger for those in telemedicine, as of course suggested. And very interestingly, only 18% of those who had their abortion by telemedicine had a dating ultrasound, and this was really different. Well, what happened with these women with the cohort of women who didn't have ultrasound, dating ultrasound, all of them systematically? Well, the complete abortion rate was exactly the same, 89.9, 90.1. No continuing pregnancy in these small samples. You can note that there were 199 compared to 182. Aspiration for completion, there was no difference. And for loss to follow up, it was about the same. Of course, in terms of complication, it was very difficult to really have a good comparison because the numbers were very small. But as you can see, very few difference. And it was interesting to see that 7 women had extra misoprostol for incomplete expulsion. And this is certainly because these women were going to the clinic and probably eventually having more care because they would see a physician directly than when they were by telemedicine. What about the study done in Indonesia? So it was telephone line Samsara in Indonesia for medical abortion under 13 weeks, okay, which is a little bit different from the 2 previous study where it was under 70, up to 70 days, which is 10 weeks. So they compared the Samsara telephone line counseling information prepare and post versus the Samsara counseling plus information pre and the smartphone app for the pair and post medical abortion. And the app was called Mrs. Mizo. And so there was complete abortion in 74.8% of the patients, almost 8% incomplete abortion, and 17.3% who were not sure, but there were no difference in all these 3 things between the 2 groups. So they reported just the complete picture. And there were no difference in general perception of preparation to medical abortion, in perception of preparation to bleeding, to pelvic pain, to confidence with mifepristone taking and misoprostol, and support during medical abortion. So that was interesting to see that in a country where surgical abortion is very difficult to access, this telephone line can be very helpful, and the app also can replace the telephone line for part of the process. As of Women on Web, it's not easy to find specific studies on this in particular. Most of the time it's within meta-analysis or systematic review. And I present to you a systematic review of studies that were done between 2003 and 2018 using all kind of type of access. And complete abortion rate was 95%, hospitalization rate 0.8%, failure rate 0.6%, acceptability of side effects 87%, global satisfaction 95%, and many women would take the same option again or recommend it to their best friend. Another systematic review from 2012 up to 2018 from Europe, Canada, and Australia. You have approximately the same kind of data, except for the rate for curettage for retained product, which goes from 0.9 to 9.3%. And this is because the 19.3% is related to the fact that some women had medical abortion quite late in their pregnancy, possibly in their second trimester, because of absence of ultrasound dating in some areas, especially the areas where abortion is illegal, and in some countries of Europe. So COVID happened in March 2020, and it had a lot of influence on abortion services and practice. At that time, it was very interesting to see that many societies decided to provide guidelines on how to care for abortion patients during these pandemics. At SOGC, we did this work. Sheila and myself were involved in such work to provide guidelines to health professionals on how to deal with contraceptive methods, but also with abortion practice. So why was it important to eventually for women to get medical abortion via telemedicine during COVID? Well, first of all, social distancing, difficult to access health services because of reassignment of personnel, leave of absences, some COVID, health professionals contracting COVID, a reduction in or interruption of public transportation, reduction of mobility between regions and provinces, economic uncertainty, increase in familial responsibilities, increase in domestic violence, anxiety towards COVID and pregnancy or COVID healthcare environment, positive test to coronavirus, and the use of internet. We all became very used to internet, and we're still using the Zoom very much. So a good opportunity to use telemedicine. So as I said before, many societies, medical society, the American College, the College of New Zealand and Australia, the Royal College, the SOGC, the Collège National des Gynécologues de France, so the gynecologists from Brazil, from Italy, many places contributed to this knowledge. So many of them gave new recommendations. First of all, during pandemics, abortion services should be considered as essential services. It was not all countries who said so, okay? Like in Hungary or in Poland, it was not, in Poland it's forbidden, and in Hungary it did not pass to be an essential services, causing a lot of problem to women, and this is why they would rely on Women on the Web to say something. Then abortion service should be offered without delay, so as soon as possible. It is important to reduce the risk of contamination between patients and healthcare professionals and to apply protective measures against COVID. As a matter of fact, this was we had to provide for the SOGC a few guidelines regarding the use of anesthesia at the time of abortion, and sedation analgesia is certainly the best thing compared to general anesthesia. Because of the pandemics, medical abortion should be favored because indeed it can be provided through virtual consultation. And even in Brazil, where induced abortions are forbidden, they also recommended that non-surgical approaches for first trimester pregnancy failures. So they said that the women should use bisoprostol to cure or to treat their first trimester pregnancy failure instead of getting a curettage in a hospital ground. Consultation for medical abortion should mostly be offered via telehealth or virtual consultations rather than in clinic. So many societies said so. The other interesting thing was the introduction of low and no test protocols, which goes along with the telemedicine healthcare, but which is a slightly different notion about medical abortion. So what do we mean by low and no test protocols? Well, we mean no routine dating ultrasound, no routine blood test, no RH testing before 70 days of gestation, medication, mifemizo, taken at home, obtained from pharmacy, although in the US it was not always possible, and follow-up via telemedicine with urinary pregnancy test 2 to 4 weeks after taking medication. This aspect was particularly interesting. So what happened in Canada? Well, prior to COVID, very few providers would provide medical abortion virtually, barely 16%. But since the start of the COVID-19, we did a poll from our CAPS the data and our community of practice, and the answer was 89% would therefore provide medical abortion during the COVID pandemic. So a big switch from pre-COVID to post-COVID. In other places in the world, things happen too. This is a cross-sectional study among US abortion clinics by the end of 2020. And they did that at the first 3 to 4 months of the COVID pandemics. And they saw that several clinics, providers started telehealth or increased telehealth. It was particularly true in the Northeast and in the West. In the Midwest, it was more difficult and in the South, because there the abortion clinics are under some legislations that may hamper their ability to do telemedicine. No ultrasound was difficult to pick up, mostly in the West, a little bit in the Northeast, and not very much in the Central and South area. No RH testing became prevalent. More than 40% started doing so. No other test also. So there was, we can see that some of these clinics were really picking up on the low test protocols. Quick pill pickup. In the West, they did so, but they had the legislation for them, which was not the case in the Midwest. Mailing mifepristone, it was not seen there in these US clinic at the beginning of COVID. However, the follow-up became the major time to provide virtual care. And many of them did comply to this advice. This study is was done through what they call the Telabortion project. It was a little bit like Women on Web, but it was American. So they started by a little bit before COVID, but at the very beginning, they were all doing, you know, in the clinics that were participating, they were all doing ultrasound. But when COVID occurred, then they started doing no ultrasound to their patients by really trying to screen their patient, those who would need an ultrasound and those who would not need one. They also, for follow-up, used the urinary pregnancy test, so very few pre-COVID, and it became really more prevalent once COVID started. So what happened with this Telabortion project? Well, on a cohort of more than 1,350 patients, 52% didn't have an ultrasound. They had a follow-up of 83%, and they had complete abortion for 95.3% of the patients, which really is like what I showed you before COVID. There's no difference. Curettage in 4.1% of the patients, continuation of pregnancy around 1%, emergency visit 6%, and a lot of satisfaction, and many of them would prefer teleabortion in the future. Another very interesting study is this study of Reynold Wright. As I said before, in 2020, the Royal College of OBGYN of the United Kingdom recommended that dating ultrasound and ARH testing were not mandatory for medical abortion before 12 weeks, and that medical abortion via telehealth was acceptable. So what they did, this is in Scotland, they did a prospective study on 663 women, 16 years and over. Sorry, there are some few little French words across the lines. And they did this study from April 1st, 2020 to July 9th. So very quick registration of patients. The consultation were virtual, but they would do dating ultrasound like in all other studies that I've seen on telemedicine. If uncertain last menstrual period was present, if LMP were over 12 weeks, if abdominal pain, bleeding, or risk factors of ectopic pregnancies. They didn't do any ARH testing or other blood test, and they would give the mifepristone, misoprostol, and antibiotic prophylaxis at the hospital if ultrasound was performed, or by courier if they were not coming for an ultrasound at the hospital. They had interviewer administering questionnaires at day 4 and day 14 after meso. They had home urinary pregnancy test at day 14, and they would verify the complication rates via electronic patient records, which they have in the UK at this time. So what happened? Well, 98% of their patients had a complete abortion. No continuation of pregnancy was over 12 weeks. 78.7% did not have dating ultrasound. And what happened is that 56% of women had a gestation of 5 to 7 weeks, which make them having early abortions. As of complications, 2.4% consulted the emergency room, 2 for MRH not requiring transfusion. 8.4% consulted the clinic because of a positive pregnancy test 14 weeks after meso, which can occur, and this is why possibly it's probably better to do it 4 weeks after taking meso. Then the risk of having a positive pregnancy test will be very, very low. And 9.9 required a follow-up ultrasound. Satisfaction was very high, and 83% found telemedicine very acceptable. Another very important study on telemedicine was this historical cohort study done by ICON in the UK. The targeted population was all women who accessed an early medical abortion at the 3 largest abortion providers in England. And what happened is that this is a comparison of 2 cohorts. So one cohort before COVID and the other cohort after COVID. So from the 1st of January 2020 to the 1st of March 2020, all women receive a traditional service with mandatory dating ultrasound, which correspond to a cohort of 22,158 women. From the 6th of April 2020 to the 30th of June 2020, they offered what they called a hybrid service. No test via telemedicine or in clinic with test and ultrasound if necessary. So more than 18,000 received no test via telemedicine, and 39%, 11,000 required to be seen in clinic for dating ultrasound or other tests. All gestation were less than 10 weeks, and the mifepristone misoprostol was sent by courier or given locally when the women were going to the clinics. Teleconsultation was the first entry in the process, but ultrasound was once again done if LMP were sent in over 12 weeks, if abdominal pain, bleeding, and risk factor of ectopic were present. And they had an emergency telephone line 24/7, and once again, complications were obtained via electronic patient records up to 6 weeks post-study. So this is the kind of screening chart that they were using. So on the telephone with the virtual consultation, the first thing they were asked was, do you know the date of your last menstrual period? And if they didn't know, then they were booked for an ultrasound. Then was it a normal period, or was it especially light or heavy? If there was some confusion there, once again, they would have an ultrasound. In the last 3 months, have you been taking the contraceptive pill or other contraception, hormonal contraception, or been breastfeeding? And there they were trying to find if they had some regular cycle, and if not, they would be booked for an ultrasound. Finally, they were asked about all the risk factors of ectopic pregnancy, including the presence of an intrauterine device. So really a nice screening. Well, what did they find? Well, when they compared the traditional service to the telemedicine hybrid service, they found no difference in successful medical abortion, no difference in unsuccessful medical abortion, no difference in continuing pregnancy, no difference on those who opted to continue or to continue their pregnancy, and no difference in retained products. Moreover, in the telemedicine group, which was the one that had been screened to be able to have telemedicine, the success rate was higher than for the traditional service, because they had been screened so much that there were really no risk patients, and their side effects were even lower than in the traditional group. There were no difference between the 2 groups, telemedicine or hybrid or traditional, in terms of complications and in terms of satisfaction. As of the ectopics, there was also no difference between the 2 groups for those that were managed pre or post, but we can see here a little bit more ectopic managed post-treatment, but it didn't reach significance. But one major difference was in the mean delay to obtain treatment. With the traditional service, it would take 10.9 days to obtain the service, while with the hybrid service, it would take 6.5 days, which was highly statistically significant. So, given all this, in conclusion, we can say that components of telemedicine can be safely introduced into the provision of medical abortion. In selected population, low no-test medical abortion is comparably safe and efficient as classical or traditional medical abortion. And hybrid provision of medical abortion may not only reduce delays, but it may reduce cost of abortion care services and accommodate more patients. And in this particular regard, I think that, you know, if we want to choose wisely, we have this strategy of choosing wisely. I think we should go forward hybrid provision of medical abortion. Thank you.
I've got a question. I found it fascinating that they weren't worrying about whether somebody was Rh negative or not. What is the rationale behind that? Because of course it's ingrained in us that there's the slightest bit of bleeding and the RhoGAM is given, and yet we're inducing an abortion and not worrying about the blood type.
Okay, there are some data that shows that before 12 weeks, during the first trimester, the acquisition of fetal cell in the serum is so little that there is very little, if so no risk of isoimmunization before 12, you know, during the first trimester. However, I must admit that the data is not abundant. We need probably a little bit more data to confirm this. These are more laboratory data, and during COVID, it made sense not to have patients come to the clinic because of COVID, but also because of availability of WinRho, because WinRho is also a problem, the access to WinRho. But before, in the SOGC guidelines on low and no test protocol, which we actually wrote together, Sheila and myself and other colleagues, we put the limit at 56 days. And but in the UK, they were going all the way to the end of the first trimester. So I don't know, Sheila, if you want to say more.
I think the UK only brought in the RH for medical abortion. Like, they didn't use it in the beginning anyway. And then they brought it in, I think, somewhere in the last 10 years, and now they've taken it out again. The up to 12 weeks is what's new to me. And I agree with you, I'm a little bit nervous. I'm very comfortable with the 8 weeks and probably with the 9, but when you get over that, the proof is in the very rare event that you have an isoimmunization, which you're not really going to pick up for, you know, it's going to take a lot of abortions to actually be able to determine that, and potentially a next pregnancy to really figure that out, right? So
the other thing, just to finish, there was a study where we compared the rate of immunization was calculated in the Netherlands. Well, they do not provide WinRho's anti-RH to their patients up to 12 weeks, and they have barely no cases. So in the Netherlands, where they did this practice for a long time, it was kind of unnecessary for them to do RH in the first trimester of their patient who had abortion, and even surgical.
Yeah. So are we going to extrapolate that into the care of normal pregnancy if they have, you know, little bleeds and that in the first trimester? Are we going to hear the SOGC telling us don't bother with RhoGAM?
No, not yet.
it's the interest of the hematologists that are duking it out with the maternal fetal medicine people and the gynecology people. There's a lot of different opinions and it depends on who's, Canadian Blood Services is a pretty powerful voice. And they're the ones who often make these kinds of recommendations.
No, we're not yet there. And we're not yet there neither for the miscarriage, because we don't have the data for the miscarriage. So, but we know that there is a research team in Philadelphia who is, which is working on this at this time. So there should be some published data in the next few years.
Good. Any other questions, anybody? No, I don't think we have any more questions, but we do have, comments. It's been a great presentation. And for people who come late or people who aren't able to come, we will put it out on a recording. But Sheila, should I just delay that by about a week or so? I can't hear you.
If you could delay it till the next week, that would be great.
Oh, okay. Yeah, it might take Michael a while to put this out on the website anyway. Thank you very much. I think we all learned a lot. I certainly did. And it will be available to our other members, if they were unable to come. And I'm sorry for being so late for you Easterners. It's going to be bedtime pretty soon for you. But anyway, thank you very much. And I hope everybody learned a lot. Thank you.
Thank you. Good night.
Good
Thanks for
night.
asking us. Thank you. Good
Okay.
Good night. Bye-bye.
Bye-bye.